begin with our first slide, number 28. So this slide is diagnosed as acute appendicitis. Now, as such, you should be able to see the appendix in this slide. So, as what I have lectured to you on disorders of the small and the large intestines. So, what is the pathognomonic microscopic finding in acute appendicitis? Neutrophilic infiltration in which particular layer of the appendix? No. In that layer, which is? So you have the mucosa. Submucosa. Next to the submucosa is muscularis externa layer. There should be neutrophils infiltrating the muscularis propria or muscularis externa. Look at the great number of neutrophils causing the liquefactive necrosis of the wall of that appendix. Okay? If you look at this portion, so the mucosa, the submucosa, the muscular layer, even the serosa layers are now completely replaced with pus. Okay, that's the microscopic appearance of pus. Neutrophils that are closely spaced with each other. So that all cases of acute appendicitis must undergo appendectomy. Removal of the appendix. Because what is the danger? Aside from sepsis, rupture. So this will eventually become ruptured. As liquefaction continues, the wall of the appendix becomes weaker and weaker, so increasing the possibility of rupture, which may cause peritonitis, which will now increase the mortality rate. So that is why all cases of acute appendicitis must undergo appendectomy. Once you diagnose acute appendicitis, you should refer that patient to a surgeon for appendectomy. Otherwise, that patient will have a danger of having a perforated appendicitis. Next slide, number 112. This is diagnosed as amoebic colitis. What is the positive agent? Entamoeba histolytica. Now, although not clearly shown, okay, in this slide, you will be able to see the remnants of the eroded mucosa of the large intestine. And then, suddenly, in the area pointed, the mucosa, including the submucosa, disappears. Because that is now where the ulcer is. Okay? So the ulcer in amoebic colitis has narrow neck and wider base. Okay, wider base, narrower neck, imparting the characteristic shape of flask. So that is the abnormality that you need to be able to see in this slide. Now, you should be able to see also the trophozoites of Entamoeba histolytica, but that will take some time. So, anyway, you have seen the trophozoite and the cyst of Entamoeba histolytica in your parasitology already. So, madugayan ta kung mahita ta sa trophozoite. Anyway, rest assured that we will not be showing you the trophozoite in the practical exam. That should be in the scope of parasitology already. So, for this slide, just be familiar with the shape of the ulcer. Narrow neck, wider base. Next slide, number 113. I believe I have lectured this disease with you in the diseases of the small and the large intestine. Now, in this slide, you will be able to see necrotic segment of the large intestine. I'm sorry. Anyway, those should be the glands of the large intestine, the muscularis mucosa. Look at the disappearance of the mucosa in that pointed portion. Okay? So, we are not able to see anymore the components of the mucosa in that pointed area because the glands and the lamina propria have developed necrosis already. And then on top of the necrotic mucosa is that pseudomembrane, which is composed of pus, necrotic debris, and fibrin materials. Okay? So, that's the microscopic characteristic of pseudomembranous colitis. The pseudomembrane will be composed of pus and necrotic debris and fibrin materials. You will be able to see the pseudomembrane on top of the necrotic mucosa. And then another characteristic feature of pseudomembranous colitis is that you will be able to see dilated glands. Glands are dilated, and then some portions of the epithelium lining the glands are necrotic. So necrotic, dilated, colonic glands, and then when you shift to higher magnification, you will be able to see that the lumen of the glands will become filled with mucus and neutrophils. You will be able to see that same picture in your Robbins. If you will go back to the chapter of gastrointestinal tract disorder, you have a dilated gland with some epithelial cells that are necrotic already, and then the dilated lumen will contain mucus plus neutrophils. And then on top of the necrotic mucosa is the pseudomembrane already, which is, again, composed of necrotic debris, fibrin materials, and pus. So what is the virulence factor of Clostridium difficile? Is it producing an enzyme, an endotoxin, or an exotoxin? And then what is the mechanism of action of its exotoxin? Why will the cells in the epithelium eventually die? Because of that exotoxin. And then kindly review on the three major predisposing conditions. What are the three major predisposing conditions? Antibiotic use, what else? Old age, and then the third is prolonged hospitalization. Next is slide number 111. Okay, for you to appreciate better the abnormality present in this slide, we need to review the wall components of the large intestine. So you have the mucosa, starting from the surface to that portion of the mucosa which is composed of smooth muscle fibers, which should be called muscularis mucosa. Below the muscularis mucosa is what layer? Submucosa. And then external to the submucosa is muscularis externa layer. Now, So you have the mucosa and the submucosa. Okay? So let us follow now the event on this mucosa. Look at the sudden invagination of the mucosa in that pointed area. And then the mucosa actually goes deep into muscularis externa layer already. Can you still see the submucosa? Separating the mucosa from the muscularis externa? No. Sometimes there is even full thickness invagination of the mucosa plus some portions of the submucosa into the adventitial layer. So that is the outpouching of the mucosa and the submucosa layers into the wall of the large intestine. How do you call that abnormality? Diverticulum. Once it becomes infected, diverticulitis. Okay, so you should be able to see the mucosa within the layer of the muscle or even sometimes to the adventitial layer to come up with the diagnosis of a diverticulum. And because that diverticulum is infiltrated by mononuclear cells, okay, is indicative that that diverticulum has developed chronic inflammation. That's the label in your slide. Chronic diverticulitis. Can you still remember the complication of this condition? You will be encountering many cases of this disorder in your clerkship, in your surgical rotation. You should be able to predict the complication of this condition more effectively. So because the wall becomes markedly thickened, perforation. And then once it becomes perforated, on X-ray, on CT scan, the perforated diverticulitis will look like cancer. Like cancer. In fact, there is an anesthesiologist who was operated for a segment of the large intestine was removed because of suspicion of carcinoma. So fortunately on biopsy, it was only a ruptured diverticulitis. So it mimics the radiologic appearance of adenocarcinoma, perforated diverticulitis. Next slide, number 105. In this slide, you will be seeing one type of inflammatory bowel disease. How many types? How many major types are there? Two. Crohn's and ulcerative colitis. So, although ulcerative colitis is called ulcerative, Crohn's disease, we will also be able to see ulcers, which are even deeper in involvement than ulcerative colitis. Sometimes we will be able to see the entire thickness of the bowel wall developing fissures in Crohn's disease. Because in Crohn's disease, the mucosa will develop inflammation. The submucosa will also display inflammation. The muscular layer, that slide, is even also displaying inflammation. And then the serosal layer is also inflamed. How do you call that type of transmural type of inflammation? And then so in this slide, you will be able to see that ulcer. Excavation of the mucosa and the submucosa underneath the ulcer is the inflammation, which involves not only the submucosa but the muscularis and the serosal layers. And then distinct in Crohn's disease is the development of that type of inflammation which is characterized by the presence of activated macrophages. What is the other name for the activated macrophages? Epithelioid macrophages. And because of the absence of caseous necrosis in that inflammation, how do you call that? Non-caseating granulomatous inflammation. Okay? Sometimes the non-caseating granulomatous inflammation will form Langhans giant cells. Similar with what you have seen in tuberculosis. Minus, again, the caseous necrosis. So we are lucky that we are able to see the granulomatous, non-caseating granulomatous inflammation in this slide. In the other slides, what are present only are the ulcer and the transmural inflammation. Hello. Uh-oh. Text. Text. Pag-i-process lang niya kung ba yung case. Okay, thank you. Now, our next slide, 109. In this slide, you will be able to see again an ulcer. So you have normal surface of the mucosa. Look how extensive the degree of inflammation is. Okay? The dark color of the lamina propria is imparted by the presence of numerous lymphocytes, neutrophils, and macrophages. Okay. So those are the lymphocytes, neutrophils, and macrophages. And then, it's called ulcerative colitis because you will be able to see that ulcer, which has a shallower involvement in comparison with the Crohn's disease. And then the inflammation in ulcerative colitis is limited to the submucosa and submucosa only. Although in this slide, there are some inflammatory cells that are present in the muscularis externa, but technically there should be no inflammation involving the muscularis externa and adventitia in ulcerative colitis, because as what we have learned in the lecture and in Robbins, inflammation that will develop in ulcerative colitis involves only the mucosa and submucosa layers. Next slide, number 106.
Blood vessels and vessels.
Dilated blood vessels. Vasodilatation. So I suppose you have seen this slide in hemodynamic disorders already. So in this slide, you will be able to see the mucosa and the submucosa layers of the small or the large intestine. Small because of the presence of the villi. And then look at that pointed region. Can you still see the villi, the intestinal glands? No. What color can you see? Red. That's why it is called the red type of infarct. Okay. Let us see the transition. So in that pointed region, can you see the pointer? So I am now pointing small intestinal glands with still viable epithelial cells. Okay? And then that area, there is now decrease in the number of intestinal glands. The other intestinal glands are not visible anymore because they are now necrotic. And then we are now seeing extravasated blood, thus the red color of this infarct. What are the what is the major predisposing condition why red infarct develops in the GIT, particularly in the intestine? White infarcts develop in solid organs and in organs with single arterial supply. How about in the case of the intestine? Okay, the nature of the arterial distribution in the mesentery, they overlap with each other, producing collateral circulation. So that's the milder form of ischemia, and in this portion you will be able to see transmural infarction already. Mucosa is infarcted, submucosa is infarcted, muscularis layer is infarcted. Transmural. Next slide, number 81. You have already seen this slide last semester. In this slide, you will be able to see the normal surface of the smaller, the large intestine. Large intestinal mucosa. Okay? And then, starting at that point, you will be able to see that mass protruding above the surface of the mucosa. And because the mass is composed of glands, it is called an adenomatous polyp. What is a polyp? A mass that protrudes above the mucosal surface. Okay? A mass that protrudes above the mucosal surface. Now, I have lectured to you about polyps of the GIT also. Look at the color of the glands in the polyp. Darker than the normal glands of the large intestine. Let us begin reviewing the histology of the large intestinal glands. What is the epithelium of the large intestinal glands? Okay, at this point, pay attention to the size of the nuclei and the location of the nuclei. Small and parabasal. Now look at the nuclei of the epithelial cells lining the glands in the polyp. Are the nuclei small?
No.
What can you say about the intensity of the color of their chromatin? Hyperchromatic. How about the location of the nuclei? Are they still aligned parabasally? No. There are nuclei retaining their parabasal location. There are nuclei at the middle of the cell. There are nuclei even at the apices of the cells. There is this organization of the epithelial cells. How do you call that change? Distillation. That is why an adenomatous polyp is associated with the risk for malignant degeneration into adenocarcinoma. We will be studying adenocarcinoma also here. So notice that the glands appear seemingly malignant already, as the nuclei are large and hyperchromatic. The main point that will make us say that those glands are not yet malignant glands is that the glands are still separated by lamina propria. So they have not become fused with each other yet. So when they become fused with each other, it is indicative that epithelial cells are already invasive. They will now be disrupting their basement membrane, infiltrating the lamina propria, and then when the glands become fused with each other, It is also indicative that epithelial cells are invasive already. One property of malignancy. This slide is diagnosed as hemorrhoids. What are the two types of hemorrhoids? And external. Now this hemorrhoids is covered by that epithelium. What is the epithelium point of it? Defined squamous keratinizing. Internal or external? External. Now supposedly, we are to see a dilated vein in this slide. But the vein, the hemorrhoidal vein in this slide has developed thrombus already. That's the clot occupying now the lumen of this hemorrhoidal vein. And then as you can notice, we will not be able to see anymore the tunica intima, media, and adventitia because this blood vessel has become infarcted already from the complete obstruction of its lumen by that thrombus developing inside this hemorrhoid. And because the characteristic histologic abnormality is not present in all the slides that we have, which are labeled as hemorrhoids, we will not include this in our practical exam. The next slide, number 209. Small or large intestine? Small because of the villi and the plica circularis. Okay. And then just like in the large intestine a while ago, in this slide we will be able to see that mass protruding above the surface of the mucosa. And then when you examine that mass, it will be composed of what structures? Glands. So that, how do you call that mass which is composed of glands and protruding above the surface of the mucosa? Adenomatous polyp. And then when you shift to high power magnification, you will still be able to see what change in epithelial cells? Dysplasia. Adenomatous polyp. Okay. Next slide. Number 35. Okay? Small or large? Large. I have seen adenocarcinoma of the stomach already. So anyway, this is very easy to identify as the large intestine because of the numerous number of double cells. Look how small the nuclei are and their characteristic parabasal location. Okay? Now, if you follow the mucosa of this large intestine, you will be able to see in that pointed region, or unfortunately, the stain is very faint already. Oh boy. Anyway, benign colonic glands, and then the glands in that pointed region are darker in color already. However, they are still separated by lamina propria, dysplasia. And we will be able to see the transition from benign to dysplastic glands until in that point, palag na ako para sa slide 1. Till in that portion, the glands have become fused with each other already. That's the characteristic appearance of adenocarcinoma. Fusion of the regularly shaped glands that are lined by epithelial cells showing large and hyperchromatic nuclei. And then, more evidences of malignancy here. Fused glands, which are now seen in the submucosal layer. And then if you go deeper, nagawas na ganyan din sila sa adventitial layer na. Look at the fats surrounding the wall of the large intestine. So, very colic area that is supposed to be the muscles in the muscularis externa, infiltrated by the irregularly shaped and fused malignant glands already. So, what is the road for metastasis? Adenocarcinoma of the intestine? Lymphatic. So that is why the regional lymph nodes are the first organs to be metastasized. After the regional lymph nodes, what organ follows next to be metastasized? Not the lung. The liver. Why?
Blood supply.
Blood supply. Portal circulation. Now, majority of carcinomas will have hard consistency because of that characteristic fibrotic response of the connective tissue to the presence of the cancer cells. How do you call that fibrotic response in neoplasia? Desmoplasia. Our last slide, number 107. Let me look first for the characteristic pattern of arrangement of the tumor cells in this slide. Okay, in the exams, you should be able to see that field. Where the tumor cells are arranged into nest pattern or Zell-Ballen pattern. You have seen this pattern already in the tumors of the respiratory tract, where the tumor cells display uniform round nuclei, and we will not be able to see plasma membrane for individual cells because their cytoplasm appears to be fused with each other. So in what neoplasm of the GIT and respiratory tract will you be able to see that pattern of arrangement? Where patients may present with paraneoplastic syndrome because those cells may produce neurotransmitters or hormones. Carcinoid tumor. Okay, just memorize that characteristic nest-like Zell-Ballen pattern of arrangement of tumor cells with round, uniform nuclei and fused pink cytoplasm. Characteristic microscopic description for carcinoid tumor. So, would you like to have a practical quiz on these slides next meeting?
Yes.
See you next meeting. See you next week. And hopefully, wala na ibang view.